Hello, everyone. Good afternoon, and welcome to the very first episode of Dr. Tristan's Anaesthesia Tutorials. I am quite obviously Dr. Tristan Leonard, and this is the first episode of my fledgling podcast, and I certainly hope that it is going to be a useful endeavor, that we're going to get to know each other, and that we're going to be able to help you guys not just become better anaesthetists, better doctors, and pass exams, but to make sure that we sort of reignite interest in anesthesia, that I explain my passion for it and why I think it's such a fascinating and brilliant specialty. And so I had this vision for the podcast because I think that there is a dearth of teaching, especially basic medical sciences as well as anesthesia. In fact, the only podcast I could find, I think, was the Royal College of Anaesthetists podcast. And so this is something new. So who am I? Well, firstly, I am Dr. Tristan Leonard. I am a specialist anaesthetist in Johannesburg, in Gauteng, in South Africa, for those of you from overseas. So what does that mean in South Africa? I did 6 years undergraduate at the University of the Witwatersrand. I then did my 2 years of internship in Cape Town at Groote Schuur and Royal Red Cross Memorial Hospital, Children's Hospital. I then came back to Joburg for my community service, where I had a brief 12-day stint in pediatrics, and then was moved by request into the anesthesia department, where I was fortunate enough to be able to do my DA in my ComServe. And I was one of the, I think, last cohorts, or if not the last, who got a reg post straight out of community service. So I then did my 4 years at the Wit Circuit, where we rotate through Chris Hani Baragwanath Academic Hospital, Helen Joseph Hospital, Rahima Musa Mother and Child, Charlotte Maxeke Johannesburg Academic Hospital, the Wits Donald Gordon Medical Center, and Klerksdorp Hospital. And after my 4 years, I then stayed at Barra as a consultant for 5 years, where I did cardiac anesthesia, pediatric anesthesia, neuro anesthesia, and pretty much everything else in between. And I was and I'm now an overall convener for the Part 1 exam. We also, in the last couple of years, have redone the Part 1 curriculum, and we have finally introduced a integrated paper, whereby physics, pharmacology, and physiology are all in one paper now, and I think it's a much more superior examination. So that's a bit about me. I love my job. I really do enjoy. I get to do what I love most days, a lot of days. I love anesthesia. As people say, it's an art and a science, and I love both sides of it. And then me personally, sort of normal, run-of-the-mill South African person. I always joke, I'm just a centrist, and the world's gone so crazy that now they call me far right. But no, I love political podcasts, Megyn Kelly, Ben Shapiro, Charlie Kirk, Sean Spicer, Mark Halperin, etc. I love current events. I love the royal family. My new obsession is the Daily Royal podcast. And I love to cook. I love to bake. I just threw a Christmas in July. Did a 4-course meal for 16 of my friends and family. I play tennis and I play paddle. I have 3, soon to be 4 wonderful animals. And I really do live a beautiful life, and I'm privileged. And I have been given so much that I really wanted to put together something that could have an impact in the whole country, and I'm hoping in the greater English-speaking world, medical world. So what is the point? What is the plan? Why are we here? So my vision, and I hope you will stick with me on this, is to introduce 2 hours, provide 2 hours of teaching a week. So this will be based on topics or domains. So for today, we are just going to briefly touch on a history of anesthesia. I think it's interesting. And then our first segment will be pediatric anesthesia. And we should have about 12 to 20 episodes, depending on how far we get. So that's going to take us the next sort of 6 to 12 weeks, depending on how many topics you guys want in pediatrics. So the way that I envision it working, today will just be a short 30-40 minute maybe presentation. And then I'm also going to release the first talk on pediatric anesthesia. These will all be for free. However, I do envision that this is going to be a subscriber model with a small subscription fee that I will still determine. The reason for that is that it just takes my time, my effort, as well as I was horrified to find out how expensive it is to host on Apple, Spotify, and YouTube. So please assist me with that. You're all doctors. I know I'm not going to set it at an exorbitant amount, I promise. But remember, it'll just ensure the quality of the production of the program, as well as the regularity with which I'll be able to deliver episodes. So we'll release 2 one-hour teaching episodes a week. And as I said, we're going to start off with pediatric anesthesia. So the first sort of 30 minutes of each episode will be free, and then the second half will be behind the paywall. Once you subscribe and are part of the paywall, you'll not only receive the full episodes early, the day before they get dropped to the public. You will get the full episodes. You will also get the episode notes. So you will get the notes that I used and made when I made these presentations. Okay. Then for members, we're going to do an extra slot every second Wednesday. One of them is going to be Ask the Expert. So for this month, we are going to have Dr. Ernie Welsh, who is a fabulous, brilliant anaesthetist in Johannesburg. I'm sure we all know him well. He wrote the pharmacology textbook along with Prof. Annelie Milner that we all use. He's been a friend and a mentor for a very long time, and he passed the baton on to me to become the Part 1 pharmacology examiner. So thank you, Ernie, but you needed a break, and I don't blame you. So he's going to come on and talk to us about total intravenous anesthesia and target-controlled infusions in pediatrics. And then for the other Wednesday, what we're going to do is I'm going to release about a 30-minute controversies in anesthesia topic. So for this month, we're going to be talking about the use of caudal anesthesia in hypospadias repair, what the evidence says, whether there really is a risk of wound dehiscence and the need for relook. And I'm going to present you the pro and con argument on each side, and then I'm going to give you my final opinion and my practice that I do. And we'll do a lot of these. We'll do beta blockers, we'll do anticoagulation, we'll do fluid therapy, controversies in nutrition, etc., drug use, etc., etc. So on a normal week, there'll be 2 hours, and on a busy week, there'll be 3 hours. And as the program grows, if it does, well, you know, guys, I'm super keen to just do as much as I can and to put out as many episodes as possible. I do also have a vision of doing mock exams online, and we will get groups together. And for a small additional fee, we'll run a formal clinical course and exam. Mock exam, excuse me. And I'm very familiar, obviously, with the South African curriculum. So FCA, I'm sorted. FRCA, the Royal College, I'm also very familiar with their curriculum and exams. So I'm able to do mock exams for British anaesthetists as well, and American and Canadian, Australian, and New Zealand. All syllabuses I've been through very similar, and I've gone through lots of exams, both written and oral. So I think I have a pretty good idea of what is needed and of how to examine you guys effectively. So that's the vision. That's me. That's my story. I hope this is worthwhile. And I certainly hope that we grow. Like, subscribe, share with your friends, your colleagues, whatever anesthetic groups you're on, or work groups, or university groups, class groups, etc. Please, please, please share this as wide as possible. As I've said, the first 2 episodes are totally free. I just want you guys to get a view of my vision. I want you to get to know me and see if you like the way I teach and the way that I present. And if we really take off, guys, then every Friday I'll give you a 15 minutes of my hot take on current events, just for fun. Why not? So guys, what we're going to do today now is we are going to just look at a brief history of anesthesia. Okay, so basically, as we look at anesthetic milestones, the timeline, we start off around the mid to early 1800s, okay? And Crawford Long first used ether, roughly around 19 in the early 1800s, excuse me. There was then a public demonstration a few years later by William T.G. Morton. Chloroform was then introduced next, and that was by James Simpson, very famous name. I hope you recognize his name. And his most famous feat was that he got Queen Victoria to use ether as an analgesic in the birth of her son, Prince Leopold. And before this, ether was viewed a little bit suspiciously. Anesthesia was viewed suspiciously. Remember that in the medieval world, or pre-modern world, whatever you want to call it, religion was a huge part of their lives. And so the suffering of childbirth was thought to be a way of showing your devotion to God through the pain, etc. And so it was a bit controversial with the clergy that Her Majesty would have a child-free. She would have a pain-free childbirth. And so once she used it and it was demonstrated to be safe and effective, well, then the sort of anesthesia train started getting going, and it's been chugging along very, very nicely and rapidly ever since. So then there was nitrous oxide that was discovered by Horace Wells, and then reintroduced later and co-administered with oxygen. So remember, they didn't know initially that you needed oxygen as well as nitrous, so they used to use very high concentrations. And I'm sure all of you will notice here we've got ether, chloroform, nitrous oxide, cyclopropane, and halothane. And we literally don't talk about intravenous drugs until just before the Second World War. So for the first 100 or 150 years of what we would know as modern day anesthesia, where they did more than give the person alcohol, a tourniquet, and bite down on a stick, it was all gases. So it was all inhalational. So it was sort of drip masking or air bypassing a cloth that vaporizes the ether, etc. And it was very dangerous because you couldn't gauge depth of anesthesia. You didn't have an ECG, a blood pressure machine. Well, later on you had a mercury sphygmomanometer. You didn't have oxygen saturation until the 70s or 80s. So the principle is the patient pink, warm, and dry? So it would be hand on a carotid, hand on a wrist during the whole procedure, monitoring respiratory rate, so putting a mirror in front of the mouth, looking for fogging, and then crudely monitoring vital signs. So it was incredibly dangerous, but it was slow. It slowly but surely got safer and safer over the years. Then really, things changed when we discovered the barbiturates, especially thiopentone in the 40s, or late 30s it was. I think it was 36. And what this allowed was induction of anesthesia as we've come to know it. So that allowed for a rapid induction of anesthesia, securing of the airway. It was titratable. You could dose it 2 to 3 milligrams per kilogram, and it was reliable. So that really changed things a lot. And then just a few years after that, we started using ketamine, especially in the Gulf War. And then propofol came along. So it's been a very rapid evolution. You could see for the first 100 years or so, it was volatiles and analgesics, basically with poor monitoring. And then suddenly in the last sort of 80 years since the Second World War, that terrible, tragic event, unfortunately, as things do, it allowed for major technological advancements. And one of those was anesthesia. And so once intravenous induction agents were introduced, well, then we were off to the races. Okay. So if we then look here at the sort of more global picture of anesthesia, we start off here in 1846, first successful demonstration of general anesthesia. Then in 47, we had New Zealand's first anesthetic. Then in the 1850s, something called the Schimmelbusch mask was invented, and that allowed a piece of cloth or gauze to be saturated with ether or chloroform or cyclopropane, and then be placed over the patient's mouth with oxygen running over it in order to vaporize it. So very, very crude version of a vaporizer. Interestingly enough, they didn't really intubate before that because we only got the laryngoscope in 1921. We only got the cuffed endotracheal tube in 1933, less than 100 years ago. We then got a curved Macintosh blade, and thank goodness we got the Goodell airway, all right? And then in the mid-1950s, 56, the first modern inhalational agent, cyclopropane and then halothane were used. The problem with cyclopropane is it was hell of a combustible, okay? Now what's fascinating is in 1972 only do we start measuring ECG, blood pressure, etc. So we've been giving anesthesia for 122 years now, 32 years, excuse me, before this. Then we have pulse oximetry in 73. So a lot of your colleagues, I'm sure you've spoken to them, Prof. Langren or Prof. Pultz, rest her soul, or Silvio Breno will tell you about doing anesthesia without capnographs and without pulse oximetry. In 84, propofol and the LMA were introduced. In 94, depth of anesthesia was introduced. And then since 1999 onwards, we've had the introduction of neuromuscular blocking agents, measuring nerve stimulators, with accelerometers. We've had ultrasound. We've got video laryngoscopy, transesophageal echo, thermodilution, you name it. Okay, so we really do have it all. And, things have really improved in leaps and bounds. And especially in the last sort of 20 years or so. Now, it's interesting, if you look at the morbidity and mortality in anesthesia, it used to be hell of a high. And there's a famous story of the most fatal surgery in history. And this was a demonstration of anesthesia. And remember, surgical theatres, that's where we get the word theatre from. It used to be a theatre. So it was a big bed or table in the middle. And it was a gallery, like you were in the theatre, and everybody used to watch, from medical students all the way up to the professor, sometimes even the lay public. Well, what happened here is that it was an amputation. And it was done under anesthesia. And the surgeon was so proud that the patient wouldn't feel anything that he decided to do the amputation in one fell swoop. So what did he do? He cut off the leg. He cut off the assistant's fingers. And a woman in the crowd fainted and died on the spot. Well, the assistant with no fingers died first, after that. And then the patient whose leg was amputated died after that. So it's the only anesthetic in the known world with a 300% mortality rate. Okay, so things were dangerous. We had no monitoring. They were brilliant physicians, they were brilliant clinicians, but can you imagine now in a critical care scenario, in a transplant, in a trauma lap or a big neurosurgery case, that you don't have a capnograph, so or you don't have pulse oximetry? It is a bit crazy. So anesthesia was dangerous, but it got safer and safer and safer. And then it got super dangerous again. And I'm sure some of you at WITS would have heard me tell this story before. And basically it was because of muscle relaxants. So what we were doing is we were getting better at keeping you asleep and keeping you alive with gases and volatile inhalational agents. But we then introduced muscle relaxants and didn't quite realize that you could have post-operative residual curarization. And so post the introduction of the curares, there was a big spike in anesthesia morbidity and mortality until we realized what we were doing, and we improved the situation. And now, obviously, anesthesia is by far the safest part of your entire hospital journey. You are more likely to get food poisoning from the kitchen. You are more likely to slip and fall down the stairs, okay, than have any anesthesia, severe morbidity or mortality. Your chances of being killed in a car accident on the way to the hospital for your surgery is about 100 to 1,000 times greater than your chance of dying in anesthesia. And why is that? Well, it's because we're amazing and we're good at what we do. And I've trained some good registrars, he says humbly. But no, in all seriousness, it's because we realize that anesthesia is a means to an end. It's not a therapeutic device in and of itself, okay? So what does that mean? Well, that means that we have to make sure that it's as safe as possible so that we can then facilitate safe surgery. And in actual fact, surgery has gotten more invasive, more curative, bigger, bolder, etc., partly because of their innovations, but a lot of it because of ours. Okay, guys, because by keeping sicker patients alive for major surgeries or for long surgeries, etc., we're able to allow the surgeons to do more and more. And that's because there is a hyper-focused, militant sort of obsession with safety. And we modeled ourselves over the airline industry. So I'm sure you remember the tragic Tenerife plane disaster, still the most fatal plane disaster in the world. I think 456 fatalities, where there was a crash, a collision on the runway. There were two airliners on the runway at the same time, which is what we would call in medicine now a never, ever, ever event. Okay. The junior pilot knew something was wrong, but because of the strict sort of hierarchy in the cockpit, he felt disempowered and spoke up too late, and everyone died. So after that, the airline industry was incredibly focused on making sure that what they're called CRM, crew resource management or cockpit resource management, to make sure that everyone has an opinion and is taken into account. And we did the same thing in medicine. We've introduced a surgical safety checklist with a pre-op, intra-op, and post-operative team, okay? We have really been focused on making sure that the anesthetic itself does not harm you. That's why we optimize patients pre-op, whether it's nutritionally, hematologically, immunologically, physically, etc. We really have become really good at keeping very sick people alive, getting them through major surgeries. I mean, if you look at some of the patients I do for liver transplants, they come in coagulopathic, encephalopathic, with a lactate of 10. And after the transplant and all our resus and great teamwork, we get them to ICU with a lactate of 2, So these things can be done. But it is because we are hyper-focused on safety. And the anaesthetist, I always say, is the pilot of the theater. The anesthetic nurse is the co-pilot, okay? And you need a pilot flying and a pilot monitoring. So the anaesthetist flies, but you need someone helping you to monitor that you trust. So that's where the importance of a well-trained anesthetic nurse is invaluable, okay? And so I really want to emphasize to all of you that are maybe not anesthetists, that don't know, just how safe it is and just what we do every single day to make sure that it's as safe as possible. Okay, so all right, guys, that's enough of that. Let's end things here. And thank you for listening. Thank you for watching. I really appreciate it. You guys are amazing. And please share, spread the word, and let's get this going. Let's get things on track. And just a reminder, so I'm Dr. Tristan Leonard. You can find me at Dr. Tristan's Anaesthesia Tutorials. Just Google it. I'm on Apple Podcasts, Spotify, YouTube, etc. Everywhere it is. Dr. Tristan's Anaesthesia Tutorials. New episodes every Tuesday and Thursday with bonus episodes on Wednesdays. So after this episode, I will ask you to like, subscribe, give a rating, share it with your friends, and then you'll see me again shortly, and we will discuss an introduction into pediatric anesthesia. And I really hope that you guys enjoy that one as well, and that you will become part of the Dr. Tristan's Anaesthesia Tutorials family, and that we really can make a difference in terms of getting good, important, quality teaching out there to medical students and all anaesthetists. Thank you, guys.